Um, Thank you all for joining us. This is obviously our weekly CHPR seminar series. Some of you are here from the public health seminar. Some of you are here for continuing medical education. Some are just here because of the topic. We are so excited you're here to join us. This week, we're really fortunate to have an expert and a really exciting speaker come and speak with us. It's our chair of family and community medicine here in the UC Davis School of Medicine, Dr. Tony Jerant, also the former interim director of CHPR. And so no stranger to primary care research and primary care implementation, which we're going to spend a lot of time talking about today, but also has done a lot of his own research on patient experience, provider experience, and care delivery redesign. So we're really thrilled to have one of our core faculty sort of lead us off today. And so I'll give Tony as much time as possible to take us through this great talk. Thank you for joining us.
Thank you so much for the invitation and the nice intro. Can everybody can hear okay? Okay, great. So let's see, what am I not getting? Okay, so I have no conflicts to disclose. These are the objectives. So very briefly, I'm going to outline, I think it's important to make sure we're all on the same page about the nature of and the key factors contributing to. I know many of you know a lot about this, some might know a little bit less, and its detrimental effects on health in this country. And then very briefly on some prior and ongoing state and federal approaches to addressing the crisis. And then really going to focus at the last part on understanding 7 high priority recommendations emerging from a national summit that we held called Rev PC, or Revitalizing Primary Care, here at UC Davis last year with national representation. So I'm going to start at the beginning. What is ideal primary care? There are varying definitions, but this one I think has been pretty much widely adopted since the National Academies of Science, Engineering, and Medicine Committee that came up with it in 2021, and it really built on other ones from before. It's considered to be the provision of whole person, integrated, accessible, and equitable care by interprofessional teams who are accountable for addressing most of the health and wellness needs of an individual. And that's going to happen across settings and through sustained relationships with not just patients, but also families and ideally communities. And that whole person focuses on well-being primarily rather than just the absence of or control of disease. So I think people are pretty familiar with that. It is a lofty ideal right now in the United States compared to where most people are in practice. And primary care is critically important to the health of America. So it's foundational, and we know from ecological studies as well as some patient-level data that more exposure to primary care that approaches or meets that ideal is associated with better health and even better longevity. This was a person-level study that I participated in using MEPS data that had some indicators of some of those core primary care attributes of continuity and comprehensiveness. And the higher the attribute score, meaning the more that it was approaching the ideal, the lower the adjusted hazard ratio for mortality over a short period. And you can see it's only significant at the top, but there's a clear trend in that direction, even for lesser degrees of perfection, as we might say. And then at an ecological level, you can see this was one study where they looked at the change in life expectancy associated with having 10 more PCPs in an area as compared with baseline. And the sort of the dose response size was basically, you can see with those confidence bars and point estimates, didn't matter how you specified the model in that study, there was a significant gain in life expectancy. And those may look fairly short, but remember, those are average effects. And of course, that means that some people might end up having much more significant expansion in their longevity. And this is just looking at, longevity. There's obviously other things that could be looked at. But that's pretty impressive, and there aren't too many other things in healthcare that do that. It's a key equity lever as well. It's been shown to be the most efficient and fair and accessible way for people to enter healthcare. And this is just one study, for example, where they looked at just simply who had visit rates in different specialties, looking at Black versus white patients. And you can see that for family med and internal med, it's pretty much a 1, the adjusted rate ratio. Most of the other specialties, it favors white patients having more visits and therefore access. But there's a couple exceptions that you could probably explain pretty readily based on things like sickle cell And then the unfortunate fact that among Black patients, there's much higher rates of end-stage renal disease and kidney dialysis. So just one indicator. We don't have time to go into a bunch of stuff. So, all right, if it's the greatest thing since mom and apple pie and the flag, why is there a need for Rev PC? Well, you know, they reaffirmed in the NASM report that primary care was such a great thing, and it actually should be considered, instead of being a commodity, a common social good, something that everybody has access to and should have access to, like clean air and water, right? But they also pointed out that primary care in the US has been slowly dying, and that's a pretty sobering assessment. So let's learn more about that. So there are a bunch of interrelated factors that have been leading for some time to a worsening crisis in primary care. This is sort of a matrix of those, and they sort of all feed on each other. We've had a shortfall of PCPs for a long time, and it's getting worse. Yeah, young clinician, this is happening for a variety of reasons. Salaries not keeping pace with those of other specialties, even though I would never plead poverty as a physician. That is a factor that new physicians look at when they're choosing specialty. Many look at it as a lot of work for too little reward, and so they don't go into the field. Those who are in the field already are either going part-time because of some of the burdens in practice I'll mention in a minute, or leaving clinical practice for other roles, or retiring early. So that's just making the shortfall worse. More and more people have no primary care source, let alone an ongoing ideal relationship sort of source of primary care. And that's more affecting vulnerable populations, but it's affecting everybody. We are really starting to see in the last decade or so, even privately insured, well-off folks have a hard time accessing the care of the kind of quality that you would want. Clinicians who remain in practice as a result of these things having overly large panels, and they don't really have the adequate funding for reasons I'll talk about to support the care teams that would be required to be able to handle those large panels. They're more likely to refer because they really don't have time to deal with the complexity. This creates delays in care, impacted specialty clinics. And there's the spiraling administrative burden of clinical care. You know, just compared to a few years ago, even with just the GLP-1s, the amount of prior auths that we have to deal with is incredible, and the amount of time that consumes. So that's been driving worsening of primary care clinician burnout, prevalence. Patients feel all of these effects. They see the clinicians are harried, the visits are short, they're often not very comprehensive or continuous, and round and round we go. So it's hard to say, it's like a chicken or egg thing, which of these things really started, but they all play on each other. And this is bad for everyone. So this graph shows basically that we are a severe world outlier, and we have been for some time, on healthcare spending. So total healthcare spending is, we're at the top. That's not in a good way. So we're spending way more than all of these other comparable OECD industrialized nations. And yet, I'll show you in a minute, we get less bang for our buck in terms of life expectancy and other things. So you can't, the OECD average of healthcare spending as a percent of GDP is 9.6%, and we're about double that. And then here is, we're also an outlier here, but in the opposite way. We're at the bottom on this curve, and this for life expectancy at birth. And you can see those curves have been diverging now for quite some time. So we're actually getting worse in our performance relative to these other countries over time. And there was a huge blip down for COVID, but we've partially rebounded. But again, this is in that same context of spending way more than all these other countries. So clearly, you'd have to infer that there's some mismatching of resources to need. And then this just shows, again, if you want to pick one more specific metric, maternal mortality, there's a lot of these that you could look at. We're here like 2.5 times higher than the OECD average in spite of all those resources. So, and then not too surprisingly, if you kind of extrapolate from this logic I'm outlining here, we are also the country among those that has the least likely for the adults to have a long-standing relationship with the primary care provider. They may be able to access, first access care, but having an ongoing actual primary care relationship is quite low compared to the rest. So what's the root cause? I mean, there's more than one, I'm sure, but a big factor is that although primary care accounts for 35% of outpatient visits in the US, and influences the majority of other costs, because this is sort of where the chain starts. frequently. We only get, depending on which definition you use, and I'm not going to get too much into that here today, but we could always talk about it in the questions. Only about 5 to, if you look at a more expansive model of primary care, close to 10% of all healthcare spending. But again, that's very disproportionate to the amount of contacts we have. This shows, for example, that hospital inpatient care accounts for only about 3% of the volume of those seeking medical care, but obviously the costs are way, way higher. Specialty care is sort of intermediate, but you can see, even though, again, 35% of visits, 17% of the resources go into specialty care in terms of spending. So, without belaboring the point, we feel like the diagnosis really of the root cause, or at least a major root cause, is chronic and severe underinvestment is crippling primary care, and it has been for a long time. And that's worsening health in the US, or at least limiting what we can achieve in health. Kurt Stange, who's one of the more senior thought leaders in the family medicine, academic family med field, said, "How ironic is it that we take one of the most complex tasks in medicine and try to cram it into 20 minutes or less and underinvest in the infrastructure?" Now, you might ask, what about California? We're different in a lot of ways, right? Well, not so much in this case. So when you look at total healthcare spending, and this is not per GDP, this is per capita, California versus the US up through 2020, and this has basically continued. You can see that we're right on par with the US, and actually the curves crossed in 2020, and we were a little above the US as a whole for per capita healthcare spending, $405 billion in total. When you look at the data, and this is a slide that, by the way, was freely shared by Elizabeth Landsberg, and we have it on our website as part of our slide presentation. So I'm not showing you anything that I'm not supposed to be showing you. It's de-identified. It is data on the percent of the spending by the health plans that is on primary care. And you can see that with these identified products, there's a range, but the average is only for PPOs about 6.3% and for HMOs 9%. So really fairly similar to what the US as a whole looks like. And what do we get from it? Well, like the US as a whole, we don't get as much as we should. So if you look at this Commonwealth Fund 2023 scorecard on state health system performance, you might say, well, 14th isn't too bad, right? But we're an awful big state. I mean, we're a bigger economy than most other countries in the world, and you would think we might be able to do better. But when you drill down on specific metrics, we don't look that great. I mean, you can see, especially compared to our Western state peers, access and affordability, prevention, avoidable hospital use, et cetera, we're down towards the bottom of the 6. And a lot of these indicators don't look so great. 45th in prevention and treatment, which is really interesting. And most of them are either not moving over time, or, as many have gotten worse as have gotten better. And again, that overall data that I showed you, 14th, there are some disparities here too, just like in the US. We have people of color, Black individuals in particular, and Native Hawaiian Pacific Islander with lower mortality than the state average, or excuse me, lower life expectancy, and pregnancy-related mortality and infant mortality higher in Black individuals, and for the infants, Native Hawaiian and Pacific Islander as well. So we're not really that much different than the US as a whole. So now we think, stemming from what I mentioned earlier, and one of the big topics of discussion at the summit was a promising treatment would be to optimize primary care spending. And why do I use the word optimize instead of just increase? It's that we don't think you can just throw money at it alone. There needs to be, the way that primary care is paid for, reimbursed, needs to change as well. And I'll talk more about that. But this study that was done, or at least helped, supported by the California Healthcare Foundation, was really, really kind of eye-opening. So they looked at the data, and they said that if they look at the data from health plans, higher levels of investment in primary care, a higher proportion of primary care spending was associated with not only better quality, but fewer hospital visits. And for the provider organizations, the data was even more impressive. They had better quality, better patient experience, fewer hospital ED visits, lower total cost of care. To the point that if those provider organizations that were in the lowest brackets could match those in the highest, there'd be a whole lot of hospital stays and ED visits avoided, and about $2.4 billion in annual spending saved. Now, when you look at the fact that we're spending over $400 billion in the state, that might not seem like a lot, but it would be a significant chunk that could at least slow the growth, right? And that's the goal that OCA has, and I'll show you that in a little while. And this is just targeting the provider organizations. If you looked also at the health plans and they were to increase their spending in primary care, you would get additional benefits most likely. So I mentioned, why does it have to be optimized rather than just increased? Well, where we are right now for payment models in primary care is way over here, by and large. Fee for service is sort of king still. And the problem with that is it incentivizes widgets, doing a lot more things, getting more patients through the door, whether or not that actually improves their health or that's the best way to address their issues. So the general consensus is that not only do we have to increase the amount of spending on primary care, but we need to provide it in ways that will allow practices to pay for the extended care team models that would help them attain that NASM definition. Because I'll show you in just a minute, most of these extended team members now that go beyond the core team, they do important things, but they don't, their work doesn't generate work RVUs, which is the way you get paid under fee for service. So, and the rates that we get per work RVU are not high enough to subsidize all these other people in the practice. So we need to be paid in a different way where there's some global payment that can help support these other care members. And granted, there needs to be flexibility among practices because not everybody takes care of the same type of patients, but these are increasingly important. I would not be able to function in my practice without our pharmacy techs who help us with prior authorizations now for the GLP-1s, just flat out couldn't do it. And they don't generate work RVUs, so. So all of that background sort of sets up why did we do Rev PC. The other big reason though was like, okay, if we're in crisis and it's hopeless, then it's not really worth doing a summit, right? But we don't think it's hopeless. And we were heartened by the fact that when we looked around, there was a lot of state level efforts underway and some that had been underway for some time to try to improve this situation. And the light blue states here on this map are the ones that currently per the Primary Care Collaborative website, which is continuously updated, by the way, they have an inventory of these states that have active state level efforts to try to either just improve investment in primary care, and often they're tied to trying to reduce the growth in overall spending on healthcare. And just a couple of years ago, California would have been a dark blue state. So it is encouraging that we're starting to see more and more. And that's really all I'm going to say about that. There are a lot of other things that could be said about some of these state level efforts, but I'm going to focus mostly today on what's happening here and what our recommendations are more globally. So that's why we did the summit. We wanted to broadcast the tenuous state of primary care, make sure people know that it's a burning platform issue for all of us and that it's affecting the health of this country. I told my parents about this data and they were shocked, frankly. You know, they're in their 80s now and they have always been told healthcare in America is the best there is. So convene an esteemed and accomplished multidisciplinary expert committee with national representation to leverage this momentum, share best practices, what is known about how to help resolve this crisis, and then a lot about what is not known but needs to be. Generate a proceedings paper that was an approximate goal with recommendations, which we're talking about today. And then we really also wanted to help build either build new ones, new multi-stakeholder coalitions, or expand existing ones to do this work, because you can only do so much with a one-day summit or a two-day summit. I'll talk more about that last bullet in just a sec. So there was hope on the horizon, we thought, although there's a long way to go. So I did want to call attention before I forget. So we do have a website for Rev PC. You can download the report there. It's linked off both the CHPR website and our department website. And I do encourage everybody to take a look at the report. It was funded by these entities. We're greatly appreciative to all. School of Medicine Impact Symposium Award, my department, and then CHPR provided tons of substantive logistical and administrative support, including our extraordinary project manager, Dominique Ridley. And Dominique played a double role because she didn't just manage, she actually contributed a lot to the programming and content. So this is the Summit Planning Committee. Every single one of these folks made tremendous contributions, could not have been as success as it was without that. And I greatly appreciate it to all of them. And then also to the Chipper staff who did amazing work. The thing ran like clockwork pretty much. I've actually, it was like in a good way, like a military operation, but no casualties. So very, very good. So I'm not going to say much about this. There was two sort of major components. There were open to the public plenaries, and then there were these working groups with the expert committee, which is really where I'm going to focus. But I just wanted to show you, we had 2 full days, basically, or 1.5 really. And the mornings were taken by plenaries. And then there was also a poster session showcasing some relevant research. But we had some great speakers. Chris Kohler, president of the Milbank Memorial Fund, who's been a real champion for primary care revitalization, for example. And then the reason I'm showing you this primarily is to show you that on day 2, we also had great speakers, but I want to showcase one thing that we got incredibly lucky with, which is that the OCA, Office of Healthcare Affordability, was just getting ready to publish and disseminate their new primary care spending benchmark. And so we were actually able to have Elizabeth Landsberg make that sort of announcement that day, which was like incredible. So I'm going to spend a couple of minutes on that because it sort of sets up the recommendations. So they have, OCA before this, about a year earlier than this summit, had established a base of 3% spending, 3% growth in overall healthcare spending per year in the state by 2029, which was a phased approach. So you could see that the per capita spending growth was a little higher starting in 25, and then it would phase down to no more than 3%. And they chose that figure because that is essentially, they didn't want to have healthcare spending grow faster than the median income of California families. So it's a very reasonable approach, I think. And they had published this, and they actually have legal authority to enforce this with health plans and health systems. So that was great. But then you ask yourself, well, how are they going to do this, right? Well, primary care turns out to be, I think very appropriately, one of their main focus areas to try to promote more high volume care and reduce the growth in spending overall. So I'm not going to say much about these others, although they're obviously all very important too. But just since we're focusing on primary care investment today, this is where I'm going to sort of talk about next here. So their statutory requirement was to measure the percentage of total healthcare expenditures allocated to primary care and set spending benchmarks that consider current and historic underfunding of primary care. And then there's other things, but that's really kind of the big picture thing for now. And so what they did is they announced at that time this target. So they said that by 2034, we want all payers and health products in the state to be spending at least 15% of their total spend on primary care services as we define them. And they do have a very rigorous definition that we won't have time to really go through. But that has been another issue, is that if you let health plans define and health providers define what primary care is, oftentimes they go to the least common denominator, which is just access to quick care. And then it was going to be a phased approach. So over the 8 years or so, they were going to look for a 0.5 to 1% per year increase in primary care spend rate per each payer and product, unless they were one of the rare outliers that would be starting at 15% above, which I'm not sure I know of any. So this was very reasonable, and it's, I think, a really smart idea to tie it to trying to slow the growth in overall spending for a couple of reasons. One of them being mathematical. If the total spending keeps going up, then the likelihood, and we're already under investing in primary care, then the likelihood you're ever going to hit a 15% target goes down. So, but it's also, I think, a good, because the two are interrelated, it makes good sense. Now, the problem is, and we'll talk more about this in the recommendations, they don't have a legal authority, legislative authority to enforce this yet. So that's just the only thing I wanted to say about the plenaries. Then I want to focus for the rest of the time on what the expert committees deliberated on, and then get to the recommendations. So here's the committee, incredible group. I do not have time to talk about all of them. You know many of these names from here, but we had representation. Just if you want to talk about different stakeholders, we had the California Medical Association represented here with Lisa Folberg. We had Sandra Hernandez, who is basically the CEO for HCI, the lead for HCI, the director. We had Pallav Barbaria from the Department of Healthcare Service or Managed Care, I believe, California Department of Managed Care. Sandra Bernheim is from CMS. Chris Kohler from Milbank, Russell Phillips and Amy Pollock, who have done a lot of research and modeling around different payment models and all kinds of things that are useful in this discussion. Monica Soni, the medical director for Covered California. Raymond Tsai, who many of you may not know, but he leads the group that works with employers around purchasing of healthcare insurance for their employees in California. Still about 40% of the population has insurance through their employer. So that's a really large group and an important voice that often gets overlooked. So I'll stop there, but it was a great group. I was like honored just to be able to sit in the same room. So really quickly, there were 5 expert committee sessions. You're going to see them numbered 1 through 4 because 3 had an A and a B part. The first one was just the first evening. I led it. It was simply kind of a getting the juices flowing session where we had 5 panelists who I had selected to have kind of a range of different perspectives, give their quick thoughts about what we need to talk about and think about as we progress through the next couple of days, and over dinner and get to know each other. What kind of emerged, though, what was interesting is we had a lot of folks comment about the fact that they knew the names, they had read their work, they had seen some of them, maybe run into a couple at meetings, but they hadn't all been in the same room at the same time. And they all had their own sort of perspective on the elephant. And it was very useful just in itself for people to be able to talk and hear those other perspectives and gain a bigger picture. And again, I would have thought that most of these folks would have already had that bigger picture. So that says a lot about the value of convening. Then the second session, which was sort of the first real earnest working session, led by Josh Fenton, programmed by Josh, was this was the charge. They were basically given the charge to consider themselves as a committee who represented payers, policymakers, and PCPs and practices, and charged with design of hybrid payment models. So, and they were given some basic assumptions. I'm not going to read all of that, but the questions then were, what practice characteristics need to be considered in the design of hybrid patient models to ensure that they incentivize the most important and impactful practice improvements? And how can those models be designed to ensure fairness so that practices, we all know they're very different at baseline in terms of their capabilities, their resources, and who they serve. We don't want to disadvantage any of them. And then there was a second question looking at how those hybrid payment models, or second 2 questions, can incentivize practices consistent with the NASM definition especially, and how will payers know if they're actually doing it? So again, I'll get to the recommendations in just a minute, but that's the questions that group deliberated on. 3A, Courtney led and programmed, and that was looking at research, how do we advance primary care research? And you can read the questions there. There was sort of 3 general components. First of all, what is the evidence, the existing evidence for primary care doing good things like they talk about in the NASM report, and what kind of high quality work has been done? What are the gaps and challenges? And there are many. And actually, do we even have a shared understanding of what primary care research is? And then how do we re-envision things for the future? That was 3A. 3B, Rich Kravitz oversaw, and his group looked at how do we bridge the gap between funding and transformation? Because again, we can't just throw money at things. They have to then, the money has to be used in wise ways, and it has to actually get to the practices. So the questions this group looked at, they were broke into 2 subgroups actually. What should we be measuring and monitoring to make sure the resources get to primary care practices and are working to benefit people? And then what are the political and persuasive strategies that need to be adopted to maximize the chances that that 15% spending target doesn't get derailed? And then lastly, 4 was on the last morning, and it was really a little more California-centric and equity-focused. It was what will need to happen, I led this one, for the OCA recommended increase in primary care spending to lead to improvements in health and healthcare, so that essentially everyone benefits, and hopefully we might actually be able to narrow or eliminate some disparities. Again, this is, if we know, I've mentioned earlier that primary care itself is inherently more equitable than a lot of the other aspects of the healthcare system, but it's not enough to just assume that passively getting access to a high quality primary care alone is going to move the needle on disparities. We know that there are biases and barriers that differentially affect different types of patients at all levels of the healthcare system, including in primary care. So that was the expert sessions. What are the recommendations? So I'm gonna, they are available on the website. I'm gonna focus on the broad 7 high priority big picture recommendations, and then I'll show you the subrecs, but there's a lot, and I don't expect everybody to process all of that by any means. And I did want to mention up front that one question we grappled with a little bit was, do you target specific actor groups explicitly when you frame these recommendations? You know, actor groups would be stakeholders basically, or influencers. And ultimately, for most of ours, you'll see we decided no, because number one, it's sort of hard to presume who exactly might take direction from the recommendations. Sometimes they can apply across multiple or maybe even all of these actor groups. And you know, it's a little bit reductionist in a way to say, well, this is really applicable just to you payers, when actually it may turn out that by seeing this, patient and consumer advocacy groups might see that recommendation and they could potentially push for change. So we, for better or for worse, we took more of a not targeting actors in the way they're framed. So recommendation 1 was increasing the proportion of spending, or increase the proportion of spending on primary care, coupled with initiatives to slow the growth in total healthcare spending. So that follows obviously very closely from the OCA recommendations, which we, you know, the expert committee felt like made a lot of sense as a whole. The sub-recommendations were to make sure that either some sort of definition like OCA's or one that's comparable that really is uniform, explicitly defined, and emphasizes continuity and comprehensiveness, which often get short shrift when healthcare systems are considering what they call primary care, is used and included in tracking spending on primary care. If you only focus on access, for example, then it may look like a healthcare system that's really not anywhere close to advanced primary care is spending a lot on primary care, right? Set and enforce higher spend rate targets, at least double the current average spending, which again would be very consistent with OCA's recs. And that would bring us more in line with comparable industrialized countries that spend less overall on healthcare, but more on primary care and get better outcomes. And then the committee also resonated with and endorsed the gradual implementation approach, because you got to meet practices where they are. Setting unrealistically short timelines for this could really backfire and create a lot of pushback as well. And then there needed to be accountability mechanisms. Now, currently, OCA is pursuing, to my knowledge, just the first bullet here, which is developing and implementing a public dashboard so that they have to track and then they can report on these things. So that alone creates some leverage for getting health systems and payers to change. But at some point, it would be nice if they had the same sort of ability to actually put teeth in this and levy fines and develop payer performance improvement plans if spending targets aren't met, just like they do have authority for the growth in overall spending. We'll see. Requiring health systems to report on the flow of the money, where is it going, so that it doesn't get diverted. We have a big complex health system at UC Davis, for example. Do I know that all of the money that's earmarked for primary care is coming to my my department and other primary care departments? I don't. Recommendation 2, pay clinicians and practices using models that support care teams in delivering high quality, equitable, relationship-centered care. So this is, again, related to that hybrid model discussion. One interesting, more specific thing that came out of this, and again, that was Russ Phillips and others who had some experience with looking at and modeling this, is that at least 60% of the payment they felt pretty strongly, and we ended up adopting this, should be provided as a more global type of payment upfront, either per member per month or some other global way of paying, and much less needed to be fee for service. And again, that's because that creates enough of incentive for change, number one, and allows upfront a reliable, steady, upfront, predictable amount of funding to support those other team members. And then a lot of emphasis on appropriate risk adjustment, which I won't say a lot about. And that, to the degree that some very unique practice types might need a unique hybrid payment models, small practices may really struggle with this initially. So one incentive the idea came up with is that you incentivize them to actually work in networks of independent practices rather than on actual change right away. Because if you don't incentivize them to do that, they may not think about it or feel like they can do it. Community clinics, I think pretty obviously they get paid differently. They have a very unique patient population. They may need special consideration. And then large practices within already well-integrated networks, the idea there was we should expect them to adopt a higher functioning primary care pretty quickly. And so you want to incentivize actual quality measures or measures that actually assess whether they have those advanced models earlier rather than later. There's no real good reason they can't do it. Pay clinicians and practices. Okay, we're still on two. The other sub-recommendations were attribution of patients becomes very important under per member per month capitation, and it's incredibly difficult to do. We've struggled with this under some of our Medi-Cal incentive plans where we have patients attributed to us, but they're actually getting all their care at Sutter. And we still are the ones that actually get the we have our skin in the game. Doesn't matter. This is who they were assigned to. So we have to work on that problem. Consider establishing state primary care stabilization funds. This was an interesting one. Wayne Altman, one of our committee members, is the chair for Family Med at Tufts and has led a very advanced legislative effort to try to establish what he initially called a trust. And he said that eventually that language started to become triggering for the people involved. So they changed it to primary care stabilization fund. But the idea is related to this notion of primary care as a common social good rather than a commodity, that it should have its own sequestered pot of money, which all the players pay into, and then the money goes directly from that fund into practices to fund primary care services. And a lot of it, if not the majority of it, is provided more as global payment. And the incentive is that the more of those advanced primary care elements that the practices adopt, the more of that money they get. So again, they have not passed that legislation in Massachusetts. It's called PC for You, but if you want to read about it, it's very interesting. I don't know that there is political will for this in most states. Massachusetts is unique, but it's an interesting idea. And then I do think reforming the RUC is something that primary care docs have long called for, could help. I will say I came across some modeling studies while I was getting ready for this talk that suggested that the impact would actually be much smaller than we'd like. If they modeled out, it's a complicated model. They looked at affiliation, degree of affiliation or lack of affiliation between different specialties, quite complicated. But their conclusion was that it would increase the payment to primary care if we had greater representation, but not by the amount that we need. So it's a small adjustment. One could question whether the whole RUC should be reevaluated, I think quite easily. Recommendation 3, assist practices in transformation to advanced primary care models. So how do we incentivize and hold practices accountable, basically? One is that if we want advanced primary care that's continuous, comprehensive, and patient-centered, then we should incentivize those things. So metrics should be developed that actually assess access to care, continuity, and comprehensiveness, and they should have to report on those things. To the degree that we pick disease-focused quality metrics, which is where most of the focus has been lately, usually with like 7 different health plans or more that the practice contracts with, all of which have their own long laundry list of these quality metrics, which may or may not actually reflect important outcomes, but more like lab tests, or did you have this discussion about something that may or may not actually be very firmly evidence-based. If you're going to pick these, which we probably should, they should be core. They should also reflect core primary attributes, and they should be important things that we see every day and that we really can manage, that primary care can really be expected to influence because we see it a lot and they have major impact on health. So Rich Kravitz came up, I think, with a really nice example with mental health, where you might look at a 3-tier approach to metrics. You might look at what are the services available in the practice. So one example would be, do they have an on-site mental health treatment option, or do they have collaborative mental health care as a model? Services received, not only is it available, but how many patients with depression actually were able to access or get that treatment in the practice. And then lastly would be where we usually start nowadays, which is what are the effects on the outcomes? So what are the % of patients with depression who attained remission based on a PHQ-9? And again, you would pick a fairly small number of metrics each year because the administrative burden and hassle factor with tracking dozens of metrics for all these different health plans is becoming prohibitive for practices. And it's not surprising then that they tend not to do very well on a lot of them. We should also in transformation monitor the impact of advanced primary care at broader levels. So not just within the healthcare system, but looking at those things that I showed in the earlier slides, like longevity, mortality, cost of care, regionally and in the community. And then a lot of practices are going to need upfront funding and technical assistance to jumpstart their transformation, because many are a long way from this. You know, again, this is an example where we didn't specify an actor or a player or a group of actors, but I would think, for example, that it might be in the best interest of payers to help support this, and health systems and governmental oversight agencies to help support this by potentially engaging practices that are more advanced, or people from those practices to act as technical consultants who can then work with the practices that aren't there to bring them along and be compensated for that. Ultimately, that's going to reap benefits for everybody, because if the payer, for example, has patients being seen in a higher proportion of practices that have their act together, ostensibly that's going to lower spending overall and improve outcomes. Yes, I think that's pretty self-evident. Almost done. Recommendation 4, we wanted to maximize the impact of primary care as a lever for equitably advancing population health. So I won't go into a lot of detail, but John A. Powell was one of our plenary speakers. He forwarded this notion of targeted universalism, which is essentially, instead of the traditional focus on saying this group's worse off than this group for this outcome, we're going to put resources into the group that's worse off, and that's where that's going to pretty much end. He proposes setting universal population health goals that would be applicable to all groups, and then looking at what are the differences and barriers and social structural systems that differentially influence these different groups. And then that's how you determine not only the intervention, but the resources that go into it. It's important for multiple reasons, especially in primary care. I mentioned everybody is suffering right now in the sense that nobody is being well served by our primary care system. And also because if you only focus on disparities, there's all kinds of weird things that can happen, including that it can narrow because both groups got worse, and actually the group that used to be better off is now worse off than they used to be, and yet the disparity will look better. So there's multiple reasons to do this. I encourage you to read about targeted universalism and John Powell's work. I think it's also incredibly resonant with what we're experiencing in the country right now with othering and the divisiveness that we see. It's a way of framing things that potentially could go down a little bit better with certain groups in our society that are working against a lot of this stuff. Yeah, I think the other thing is, have an approach where it can't just be a few practices. I mean, increasingly we're developing an almost purely two-tiered system now, where the FQHCs are taking care of the truly underserved, and other practices do very little. So the idea here would be that everybody would have to have some skin in the game, and that you would additionally pay those that disproportionately care for medically underserved. We know cost sharing and copays and deductibles and things like that do actually reduce utilization of care. That's why health plans do it. Primary care, again, if it's viewed as a common social good, why do we do that for primary care? And yeah, I think that's pretty obvious. I'm not going to say much more about that. Advocate for training of an appropriately sized primary care physician workforce. Currently, CMS and others that fund graduate medical education are not accountable to this. There is no master plans for specialty proportions. So we feel like we need to advocate for CMS and others like the VA to develop and publicly report on their adherence to policies that ensure a distribution of their GME funding across regions that is proportionate to community need. And states can also do the same with their use of Medicaid funds. And we need community governance structures to try to hold them accountable. Expand research resources and infrastructure. This relates to Courtney's session. Again, this is a harder sell now because what we're experiencing in research, but I think it's more true than ever. If it is true that primary care is good for public health and costs less and can help us slow the growth in spending, why wouldn't you want to support it? I think we have to make a very clear, articulate case for that. So we need more federal funding and other funding. We need to broaden the reach. We talked about the need for more hub and spoke practice-based research networks. In fact, again, I kind of had never thought about this. We do not have a national registry of primary care practices and core practice data elements. That's crazy. Think of the power that we would have if we had that to do analyses, but also know where we need to focus. We need to work on our measures so that they're more robust and validated, and we can get more people using them so we can increase validity and increase comparability across studies. Use more advanced methods to address the complex questions we deal with that involve things like continuity and comprehensiveness, and then build more dissemination strategies for the evidence that we generate. And then last of all, engage, educate, and collaborate with a broad array of societal stakeholders to message the vital importance of robust primary care. These were really interesting. I'm not going to read all of them, but there is no sort of primary care communication strategy that bridges all specialties that it touches, like peds and general med and family med. Why don't we have that? Why isn't there a library of evidence-based primary care marketing resources that we can disseminate? And should we actually start educating people, not just about primary care, but even just healthcare literacy in general at the primary and secondary school levels? I mean, I think we all had health classes, but I never really learned anything about the healthcare system. So, we need to educate the public about what it is, what it does, and why primary care is so important. So summing up, these recommendations were the result of deliberations from 30 national expert and thought leaders in primary care, hundreds of years of collective experience, lots of lessons learned, hard won. But again, mostly they are current best thinking expert recommendation. A lot of them do not stem from firmly research or evaluation project-based info. So as Courtney's session reflected on, and as reflected in recommendation 6 in the report, there's a pressing need for research and evaluation projects to examine these things. How successful can governmental entities and regulatory bodies and health systems be in not only pursuing these recommendations, how much can they actually attain this, but then what is the bang for buck? We have circumstantial evidence, we have some research evidence, but there needs to be a lot more. And what are the effects then on the care team, patient outcomes, population health, and healthcare spending? Lastly, what's next for us? We are drafting a summary report focused on the recommendations for BMC proceedings, which is an open access BMC journal that is PubMed indexed. I'll just share with folks, we aimed high for health affairs, and they said, well, because you guys have already put out that other paper, we don't consider papers in that situation. So we were bummed about that. Lesson learned for next time. Had a personal conversation with the editor, and they were very nice, but they said, no, thank you. And then we are going to do a webinar that's supported by CHCF coming up, we think, in mid to late February. We're still trying to get a final date. A little hour-long facilitated panel discussion and Q&A with folks that represent these different entities. Again, I would give you their names, but we don't have it finalized yet, to try to keep getting the word out and getting the dialogue, keep the dialogue moving. So that's it. I went a little longer than I intended, but we have 10 minutes. And I'm done talking. So
thank you so much, Tony. That was great.
I feel like a little bit like a carnival barker at the pace of speed there. So.
No, you covered a lot in that short amount of time. Well, now the floor rather is open for questions. You can type it into the chat or you can come off mute. There was one comment in the chat from Stephen Henry that maybe you could reflect on, and then I can open us up with a question depending on other people, but please do raise your hands. I will call on you. Stephen's comment was that other countries have short visits too. I mean, I don't think you were saying that was the only driver, but I was just curious if you wanted to respond to this idea that getting more time in primary care as a driver of improving our outcomes or improving our costs, or what your reaction to that is.
Oh yeah, no, that's an excellent point and observation, Stephen. So what I would say is that it's kind of like the funding, the amount isn't the only important thing. We have to provide it in the right way. I think for me, if I could get a good 6 to 10 minutes in every visit where I'm actually doing doctor level stuff, that might actually be okay. I mean, I'm a little skeptical. I think we need a little more time than that for a variety of reasons. I can't comment so much on whether or not our administrative burden associated with visits is the same or less than the European countries. But, the data I would point to is, you have a 15 or a 20-minute visit, but the amount of time that's actual doctor time is an increasingly small proportion of that. So I think if you had the right care team and a really efficient system, you can do a heck of a lot in, 10 or 12 minutes. I would agree with you. There are certain patients I still think we need more time with. And I've never had a patient complain about having too much time with me. They have complained, I think, if they have to wait to get to see you. But really, it's a matter of reimbursement that drives the short visit lengths at this point.
Other comments or questions for Tony? Okay, I'm gonna get it started, but I know there might be some others. You touched on how the research landscape is different in 2025, Tony, but what about the funding landscape, especially Medicaid cuts? Do you think all these recommendations, especially the first few recommendations, still hold true in a federal funding environment where overall funding for healthcare might be cut? It wasn't like they're targeting primary care specifically with Medicaid
Right.
cuts, but that would have I would
Yeah.
say maybe an outsourced impact on primary
No,
care.
I think it's going to impact everybody, and it really, I could see a lot of different scenarios playing out, and that's part of the difficulty is we don't know. If they just took what we're doing now and proportionately cut everybody, we're going to be just as bad off. Plus, there's going to be a lot of patients that can't even get care. If they are serious about, and there's been a couple of kind of lip service, vague comments given by folks who otherwise I'm not a big fan of, that maybe we'll invest more in primary care, but really nothing substantive yet. So,
Yeah.
but if, these are Sophie's choices, but if they cut overall funding, but they actually put a higher proportion into primary care, maybe that could offset some of the detrimental effects, in my opinion.
Yeah.
But,
The buffering of, yeah, that's
yeah.
great input. Ellen, I see you have your hand raised.
Hi, thank you. So much information. Question about whether we know, for example, if practices or like staff model organizations like Kaiser Permanente have a similar spending split as other types of health systems, or whether we don't have that data yet.
That's actually a great question. I don't have the data. That doesn't mean I'm sure it exists somewhere, and it might have been in that one slide. This is where it's too bad that we couldn't have our whole expert panel here, but that was Elizabeth Landsberg's slide. So they de-identified the different HMO groups by their primary care spend rate. It was the one with all the bars. So my guess, although I can't say this with certainty, is that the Kaiser was probably one of the ones towards the top that was closer to like 10% primary care spend, but I don't know for sure. It's ultimately a little hard making the comparisons, partly because they're vertically integrated, and so there are some advantages, which people probably know what that means. But they're not only a payer, but they're also a health plan, but they also have their own hospitals, and the services cover from top to bottom basically in the hierarchy. So that could entail some efficiencies where, in theory, maybe you spend a little bit less on primary care, but you might still get the same bang for buck as somebody in a non-integrated health system that spends a little more. But all that to say, I'm not sure. I'm guessing that they're probably a little bit on the higher end for primary care spending.
Thank you.
Other questions? I don't see anything in the chat. Anyone else want to raise their hand? Trying to pause. I know you guys have questions. I guess then I'll end with
You go ahead. You go ahead.
Yeah, no, I was going to say, this webinar is great. Maybe you could talk a little bit more about, is it to reflect on these specific recommendations, or to think about how to implement them, or I know you're still in the agenda, but what would be your ideal state for moving this forward in this political landscape? Is it focusing on a few of these? I mean, they're so interconnected that it's hard, and I'm biased because I was a part of this, but tell us like how to move it forward, or where would you focus your attention, and maybe how this webinar will get you closer to that.
Well, I will, full disclosure, Rich and I have not still yet determined the discussion questions, but one thing that comes to my mind is, kind of what you mentioned, like, okay, how has this OCA recommendation played out so far? Because it's been a year now, believe it or not, time flies. We did this in October of last year. So, and what issues have arisen since the new political climate? I think that is really important. And, is it bad, worse, better, or indifferent? Are we still struggling with basically the same things? And now we have that layered on top. So that's one. And then, yes, I think a little bit about if it is stalling in particular, like how do we, where are the pain, where are the choke points? And we would have perspective of, California Department of Healthcare Services and the purchasers of insurance for employers and some others. So we were trying to get somebody that would have the payer perspective, like somebody, maybe Ellis Chen or somebody like that from Centene. So I think that would be interesting. I will be the first to admit that probably what's lacking there, and I really feel like we probably need to learn from the people who are doing this really well, and is at a political level. What do we do? And of course, your seminar that you had just recently was perfect for that. But I feel like that is maybe there's more going on than I'm aware of, but I don't feel like at a physician level there's still that much going on.
Yeah. Yeah, you can, because HCI hasn't backed down on their recommendation that came out a year. I mean, nothing has changed. Even though the political environment has changed, it's not like they're saying we're not going to go towards 15% target and we're not going to, cap the healthcare cost. All that's still moving forward in the spite of everything. And maybe it's the political or communication channels that we need to lean into more to be able to make sure that the public is aware of those. I mean, I'm not sure how aware the public is of those recommendations or sort of what that means for them and sort of getting Californians behind that. So maybe that's a future thing for some of you in the audience to think through.
Yeah, and maybe leveraging, I know CMA has to be careful because it's a multi-specialty organization, but maybe CA, California Association of Family Physicians, for example, because I do think the hard part is that it takes a lot of time and effort, and physicians, I think, should be great spokespeople. But again, I think as far as the infrastructure for a real good communication strategy and implementation, it would help to have some other sort of infrastructure for that, particularly as health systems are going to be under more and more financial constraints themselves. So,
yeah, I think it's maybe some optimism and hope for the future. That's a great way to end. I really, really appreciate your time, Tony. I'm really excited that this will continue with some webinars and some other things, and maybe this will revitalize our group to think more about it. So really, thank you for all of your time. Thank you everyone for coming, and we will see you next time. Have a great day.
thank you.
Thank you.